Welcome back to The Explainer. Today, we're diving into some major AI news coming out of the ICML 2026 SD4H workshop. We're looking at a brand new population representative tabular benchmark that uses real-world NHANES accelerometry data. And what's really cool is how it pits the new foundation model, TabPFN v2, against traditional algorithms like XGBoost and ridge regression. If you work with digital biomarkers or clinical machine learning, you know bridging the gap between raw data and actual clinical safety is incredibly tough. Well, this benchmark is trying to change how we evaluate that exact gap. Here's our roadmap for the breakdown. We'll look at the tabular AI problem, check out the NHANES benchmark, pit TabPFN against traditional models, talk about hitting the biological ceiling, measure clinical safety, and wrap up with some deployment tips. Let's get right into it. Section 1, the tabular AI problem. We really need to address the elephant in the room regarding how we typically train models on healthcare data. Structured tabular data is everywhere in clinical medicine, but our public benchmarks often totally ignore how this data is actually collected. We all do it, right? We kind of blindly assume our datasets are perfectly IID, independent and identically distributed. But with clinical information pulled from the real world, we need a reality check. Healthcare data is messy. It is almost never IID, and pretending it is can lead to disastrous deployments. Here's exactly why that standard assumption completely falls apart. Real clinical datasets come with complex survey sampling, massive demographic oversampling, and really specific missingness patterns. If you just slap a standard train/test split on this, you're asking for trouble. Training your models on raw counts without applying proper survey weights means you're going to overfit to those oversampled demographics and totally wreck your calibration. You have to respect the underlying population distributions. Moving to Section 2, the NHANES accelerometry benchmark. To actually fix this evaluation gap, researchers built a population representative solution specifically designed to force models to handle these real-world statistical quirks. They utilized data from NHANES, specifically the 2003 to 2006 cohorts, to put together this benchmark. It's a group of 1,381 adults, and it maps hip-worn accelerometry and lifestyle data straight to 3 major cardiometabolic biomarkers. On the input side, we've got physical activity metrics, like MVPA, alongside your standard covariates like BMI and age. The actual task? Mapping those inputs to 3 log-transformed clinical endpoints: HbA1c, fasting triglycerides, and CRP. Section 3, TabPFN versus traditional models. Let's get to the actual showdown. It's a classic battle of the old reliable methods versus the new kids on the block. In one corner, we have our traditional heavyweights, ridge regression and XGBoost. These have literally been the workhorses of tabular data for years. And in the other corner, we have the new tabular foundation model, TabPFN v2. The researchers ran these models through the NHANES benchmark just to see who could extract the best predictive signal from the covariates and activity phenotypes. The results were actually pretty decisive. TabPFN v2 came out on top, grabbing an R-squared of 0.383 for predicting CRP, or C-reactive protein, and that was actually the strongest predictive signal in the entire cohort. TabPFN v2 just consistently beat out both the ridge regression and XGBoost baselines here. And that success wasn't a one-off. It also consistently outperformed the baselines for HbA1c, locking in an R-squared of 0.156. It really looks like, in this specific context, foundation models for tabular data are just better at reducing variance and handling nonlinearities than standard gradient boosting. Which brings us to Section 4, hitting the biological ceiling. Because this explainer isn't just a victory lap for AI, we also have to talk about some pretty hard limitations. Even the absolute best foundation models are fundamentally bounded by the actual informativeness of the data they're fed. Check out this dismal R-squared score. Less than 0.05. That is what all the models, even our winner, TabPFN v2, managed to get when trying to predict fasting triglycerides. Literally every single model just face-planted on this specific task. And honestly, this brilliantly illustrates such a crucial lesson. Architectural complexity cannot invent a biological signal if it's just not there in the sensor data. The authors chalk this failure up to known genetic dominance and super high biological variance. Basically, when the target variable is biologically decoupled from your input features, it does not matter how advanced your AI is, it simply cannot close that gap. Digital phenotyping from a hip accelerometer has hard limits. Section 5, Measuring Clinical Safety. Point accuracy is great and all, but in healthcare, we really need to know when the model is unsure. We need conformal uncertainty quantification. Because we're dealing with patient data, clinical deployment demands rigorous, distribution-free prediction intervals. So this benchmark actually mandates something called split conformal prediction. It generates a 90% prediction interval, which essentially puts a strict statistical number on the model's uncertainty. But here's the catch. You have to understand the difference between marginal and conditional coverage. Marginal coverage just means your model hits that 90% accuracy target overall across the whole cohort. And yeah, split conformal predictions successfully hit that for CRP and HbA1c at the population level. But hitting the overall average isn't enough. For true clinical safety and fairness, you absolutely need conditional coverage. Those intervals have to hold up across specific demographics, like sex, race, and age strata. And when the researchers actually ran the subgroup analysis to check this, they found localized undercoverage. For instance, the HbA1c prediction intervals were excluding the true values for Mexican-American participants at rates way over the 10% error budget. That is a massive deal. If you deploy uncalibrated intervals like that, you're going to generate systematic false negatives for specific groups of people. You have to apply stratified conformal calibration or demographic-specific post-hoc corrections to do this safely. Finally, Section 6, Deployment and Production Tips. Let's look at how you can actually adapt this benchmark for your own clinical pipelines. If you dive into the project's open source GitHub repo and pull up the collab notebook, you've got to follow these exact workflow steps. First, mount your Google Drive and upload the analytic data set. Second, and seriously, don't miss this one, you have to accept the license and export a one-time API token from the prior lab's website, because TabPFN v2 requires that token to use its weights. Once that's done, you can run the evaluation pipeline top to bottom and reproduce the tables. As you move this into your own production environments, keep these 3 critical takeaways in mind. 1. Always apply correct survey weights to your training split using pandas or stats models, otherwise your calibration is ruined. 2. Watch your peak VRAM. Foundation models like TabPFN scale pretty terribly with cohort size, so you will absolutely hit memory limits during calibration if you don't batch your processing. And 3. Marginal guarantees do not equal clinical safety. Run those subgroup coverage audits on your validation sets before you even think about deployment. Ultimately, this whole benchmark leaves us with a pretty provocative question. We've seen AI do amazing things with tabular data, but we've also slammed right into the biological ceiling of accelerometry. Are we expecting too much from sensor data on its own? If your use case requires high-accuracy cardiometabolic prediction, this research heavily suggests we should treat AI-driven accelerometry as a powerful supplementary signal rather than a standalone diagnostic. It's just a fascinating look at the very real frontiers and boundaries of clinical AI. Thanks for tuning into The Explainer, and as always, keep questioning the data.